My dear students, in this video, I am going to discuss and highlight the major changes that have taken place in the AHA 2025 guidelines for BLS and the ACLS in contrast to what was practiced before. Now, the first thing that comes in this guidelines is the unified chain of survival. So this has been the hallmark feature of the AHA 2025 guidelines, that it has introduced one single chain of survival that applies to all equally, the adults and children, in hospital and out of hospital cardiac arrest, and lay rescuers and health professionals. Previously, there were different chains, they were slightly different, which depended also on the age and setting. Now, all these have been merged into one universal framework to reduce confusions and delays. So, this unified chain of survival ensures everyone is working from the same mental model, from first collapse to long term recovery. Now, the six links of this chain of survival are these: one, recognition and emergency activation; two, high quality CPR; three, defibrillation; four, advanced resuscitation; fifth, post cardiac arrest care; and sixth, recovery and survivorship. First, look into the first link, that is to identify unresponsiveness, that is recognition of emergency activation, is to identify unresponsiveness along with absent or abnormal breathing. So immediately one has to call the emergency services, and if it is in hospital, then activate the hospital code system, the code blue. The key change in this 2025 guideline has been the earlier recognition has been emphasized, especially for gasping patients or those patients with agonal respirations, which is now clearly defined as cardiac arrest and not normal breathing. The second link is what we can see is the high quality CPR. So, in order to achieve high quality CPR, one, the provider should start immediate chest compressions and focus on correct depth and rate, full recoil, and minimal interruptions. So, why it unified matters? Because the same CPR priorities are there for everyone, everywhere. There is no mental switching between BLS versus ACLS or such kind of mindset that because I am BLS, I need not be bothered about this A, B, and C. And because I am ACLS, I will be bothered. So, such kind of mindsets have to be eliminated. And the 2025 guidelines seeks that. Looking into the third link is the defibrillation. So here it advocates rapid defibrillation. Use an AED or manual defibrillator as soon as possible. Shock ventricular fibrillation or pulseless VT early. The 2025 emphasis has been that defibrillation is not a later step, it is the core survival intervention, which is tightly linked to the process of CPR. The fourth link is advanced resuscitation. So, advanced resuscitation was previously highlighted in ACLS, and this includes advanced airway when appropriate, vascular access, medications like epinephrine, then rhythm specific management, team based care, and leadership. So, if you look into the 2025 guidelines, the change has been that advanced care is now explicitly part of the same chain. It is not a separate pathway. Next link is the post cardiac arrest care. So, in post cardiac arrest care, the elements which have been highlighted include targeted temperature management, oxygen and ventilation optimization, hemodynamic support, neurologic care, and coronary perfusion when indicated. And this is important and this matters because survival is no longer defined as the return of spontaneous circulation only. It is also the goal is to achieve neurologically intact survival. And last but not the least, the sixth link of the chain is recovery and survivorship. So, recovery is newly emphasized and it was often overlooked before. And this recovery includes rehabilitation, psychological support, and frequent cognitive assessment. Along with that, it also needs long-term follow-up and support for families and caregivers. So the major shift in the 2025 guidelines is that the cardiac arrest is treated as a chronic survivorship condition. It is not treated as a single isolated event in CLOS, etc. Next, coming to the BLS algorithms, the notable change that we see is about the use of naloxone in BLS. In 2025, this AHA formally integrated naloxone into the BLS algorithm for the first time, and this reflects the reality that opioid related emergencies are now a leading cause of respiratory and cardiac arrest, especially when the arrest is out of hospital arrest. So the timing and dosing, one at the BLS level, the typical lay exposure, one most common is the intranasal naloxone that is advocated. If there is no response, repeat dosing may be given as per the local protocol and continue BLS until breathing improves. The EMS team arrives at the site, and if it is out of hospital arrest, and patient regains consciousness. So if you see the practice now, naloxone is now considered as a core BLS skill. It is similarly treated to the AEDs. It has there is sufficient stress to make it widely accessible, simple, because it is life-saving. And it explicitly included in the BLS flowcharts and the exams. So in 2025 BLS, naloxone is an early expected intervention for suspected opioid-related emergencies, but CPR and AEDs remain the foundation of survival. Another important thing is the simplification of the choking response. In adults and children more than 1 year, if the person is choking and conscious, that which indicates a severe obstruction, the signs being that patient cannot speak or cough, silent attempts to breathe, and the universal choking sign. So what to do is to give 5 firm back blows between the shoulder blades with the heel of your hand, and give 5 abdominal thrusts, which is the Heimlich maneuver. So this repeat 5 plus 5 until the object is expelled or the person becomes unresponsive. So the 2025 choking response removes the complexity because it alternates 5 back blows and 5 thrusts until relief or collapse, and then start CPR. Now, CPR technique emphasis. This is also one of the areas where some modifications have been advocated. The compression rate one should not be too fast nor too slow. The target should be 100 to 120 to 120 compressions per minute, to avoid too slow because that will cause inadequate perforation. If it is too fast, it will cause shallow compressions or incomplete coil. Both are not wanted, both are unwanted, and both have their own complications. Next, coming to the compression depth. Compression depth should be adequate but not excessive. In adults, it is considered to be 5 to 6 centimeter or 2 to 2.4 inches. In children, it is 1/3 of the chest depth. In infants, it is also 1/3 of the chest depth. Full chest recoil. It is strongly emphasized in these guidelines that full chest recoil should be allowed, and allow the chest to fully recoil after every compression, and do not lean between the compressions. Then minimize interruption, hands on chest. Interruption should be less than 10 seconds, and ideally it should be less than 5. And continue compressions during AED charging, airway preparation, the team role changes, etc. There should not be any interruption. Ventilation, the stress is that the less is more, so but one has to avoid hyperventilation. So high quality CPR saves more lives than any single drug or any device. So that is why the maximum emphasis has been made on the CPR technique. In case of pediatrics, there has been some BLS changes like infant compressions. The two-finger method has been removed. It is preferred infant CPR is 2 thumb encircling. The choking, again, it has become 5 plus 5 pattern, that is 5 back blows and 5 thrusts. AED use is advocated to be done earlier. Adult pads are acceptable if infant pads are not available. And overall, the focus on pediatric basic life support is towards ventilation plus CPR quality. So 2025 pediatric BLS updates prioritize reliable circulation, early oxygenation, and simple repeatable actions, especially for infants. Next, coming to algorithm improvements. This is also one area where the AHA guidelines have given a lot of thrust. So there is clearer separation of shockable versus non-shockable rhythms. Shockable, that is VF or pulseless VT, where you go for CPR followed by shock and immediate CPR. Antiarrhythmics only after repeated shocks, and emphasis is on minimizing the rhythm check pauses. In non-shockable, that is the pulseless electrical activity or in asystole, CPR first, early epinephrine, and aggressive search for reversible causes at the 5Hs and the 5Ts. Then the time anchor decision points. Algorithms now emphasize epinephrine every 3 to 5 minutes, rhythm checks every 2 minutes, compressor switches, that is one who is giving manual compression, not doing CPR, switches every 2 minutes. So these are time anchored decision points. So these have improved. Then defibrillation flow simplified because there is all now a single shock strategy, immediate CPR after shock, no pulse or rhythm analysis before restarting the compressions. The other areas of algorithm improvement includes medication use has been clarified so that there is less ambiguity. Epinephrine is the routine and the uses should be in the standard dose. There is no high dose epinephrine concept. Amiodarone or lidocaine is reserved for refractory VF or pulseless VT. No routine medications for asystole beyond epinephrine. The H's and T's integrated earlier instead of being an afterthought. Reversible causes are now explicitly placed inside the algorithm groups and prompted early in non-shockable rhythms. Next, team performance embedded into algorithms. New emphasis includes role assignment shown alongside actions, closed loop communication, prompts, and CPR quality monitoring as a visible priority. So therefore, 2025 ACLS algorithm improves, simplifies decision making, anchor actions to time, and keeps CPR at the center of every pathway. Now coming to the aspect of defibrillation, the shockable rhythms, there has been established absolute clarity that defibrillation is only indicated in cases of ventricular fibrillation and pulseless ventricular tachycardia. Now, single shock strategy is strongly enforced. That is, deliver only one shock, immediately resume CPR, no pulse check, no rhythm analysis pause. And minimize pre-shock and post-shock pauses. The targets for 2025 says that pre-shock pause should be as short as possible. Post-shock pause should be ideally 0 seconds. Biphasic waveforms are preferred when they're available. Defibrillate children early for ventricular fibrillation or pulseless VT. And CPR before and after shock is non-negotiable. So that has to continue. CPR has to continue during both the pre and the post stages. And defibrillation is treated as a team skill. So every member of the team has a role to play, and it is the collective conduct of the CPR that determines the success with regard to defibrillation. So in 2025, defibrillation is a fast, decisive, CPR anchored and interruption free once shock process and then compress immediately. Coming to the medications, epinephrine, which is the main drug, sheet anchor for the for all cases, remains unchanged as regard to its dose, that is 1 milligram IV or intraosseous, interval every 3 to 5 minutes, standard concentration only. But what was clarified was that in cases of non-shockable rhythms like pulseless electrical activity or asystole, you have to give early epinephrine. As soon as access is obtained, you have to give. And in cases of shockable rhythms like VF and paroxysmal VT, give epinephrine after initial defibrillation attempts, not before shocks. High dose epinephrine, as I told before, is explicitly discouraged. The antiarrhythmics are used when there is refractory ventricular fibrillation or persistent VT, only in recommended options like amiodarone and lidocaine. Lidocaine is the possible alternative that has been suggested. Magnesium has a very narrow use. It is only indicated for Torsades de Pointes and suspected severe hypomagnesemia. But what is remembered is that the time matters more than the choice of the drugs, and therefore the 2025 medication strategy is minimalist. But it is time focused, epinephrine on time, antiarrhythmics only when indicated and never at the expense of CPR or defibrillation. Some routine use of some interventions are not recommended anymore because AHA explicitly discourages the use of interventions that were commonly performed in the past resuscitations without any proven survival benefit. And this includes routine double sequential defibrillation, routine electrical pacing during cardiac arrest, early advanced airway at the expense of CPR, routine use of certain medications like atropine, soda bicarb, calcium, etc., and overuse of monitoring and diagnostics during the arrest. So the 2025 ACLS guidelines intentionally removes low-value interventions to protect what matters most, that is uninterrupted high-quality CPR and rapid defibrillation. Another important point where these guidelines have included is the team performance and feedback. High performance CPR needs to be performed. There should be clear role assignment by the team leader before starting CPR. There should be closed loop communication, which should be explicit. Explicitly, it is required that if the leader says 1 milligram epinephrine to be given, the other person after administering should also say the 1 milligram epinephrine given, and then the leader must also respond saying that confirmed. So that is the way how closed loop communication operates. A, B, and then again A. So this can also help in improving the quality. Time awareness and task anticipation, real quality CPR quality feedback. Then one person can be there as the CPR coach or quality officer role who will not perform any duty, but who will only go into action and only will open his mouth when the quality of CPR deteriorates. He is going to continuously monitor the quality of CPR from the head end of the patient. And the last but not the least, post-event debriefing. It is very important, particularly after the arrest. So that should be done properly by a senior member who is well versed in the language and likewise. So the 2025 guidelines treat resuscitation as a team sport, structured rules, clear communication, and real-time feedback. So these are essential life-saving goals. Next, it also includes updated course materials because course manuals, videos, and slides on the 2025 guidelines, they reflect unified chain of survival, naloxone integration into the BLS, simplified choking algorithms, pediatric BLS technique changes, CPR first, interruption free philosophy, and team performance and feedback emphasis. So the older materials like the solo rescuer focus, step-by-step narration, unrealistically cam settings, these are gradually going away. And the 2025 materials bring into the limelight team-based arrests, realistic noise and urgency, role assignment and leadership, closed loop communication showing explicitity, so on and so forth. So the 2025 updated course materials shift resuscitation training from memorization to mastery, which emphasizes realistic teamwork, CPR quality, and decision making under pressure. Next is the performance-based assessment. These are also part of the curriculum, and this has been included in the AHA guidelines of 2025 with specific reasoning, which has been mentioned against them in the guidelines. Now, the CPR quality is directly assessed. Mega codes are evaluated differently. Time critical actions are scored. Time behavior is actively evaluated. And these alone will not guarantee success, like memorizing of drugs, memorizing the causes of H's and T's, etc. So from that point of view, one has to only adhere to those principles which guarantee success. And structured feedback and debriefing. This is also very essential and has been included in the guidelines. So 2025 performance-based assessment model measures and real-world resuscitation competence prioritizes CPR quality, timing, and teamwork over memorization. So, in summary, in a nutshell, we have to think if it asks any five important changes which have taken place in contrast to the previous guidelines, the answer would be in the area of shared chain of survival. The key change is the unified across all ages and settings. Then the BLS, it has included naloxone and updated choking steps. Pediatrics eliminated two-finger compression, revised AED and choking guidance. ACLS has more precise algorithms, refined shock and medical timing, and there is only team focus. Training, updated education materials and feedback driven performance. So all of these are the changes that have been crept in the 2025 AHA guidelines, and probably a lot of important things are await clarification, and we may soon get these clarifications. Until then, we need to continue and understand the guidelines very clearly and continue with our practice of critical care. Thank you.